All right. Hello, everyone. Welcome to our last webinar of the spring 2023 season, if you will. Very pleased to introduce our presenter today. Merna Ihab graduated from the Faculty of Dentistry at Alexandria University in 2017, after which she became a teaching assistant and research assistant in the Department of Dental Public Health in the Faculty of Dentistry. And then in 2019, she started to pursue a Master's of Science in the field of dental public health. Her current research works or seeks to fill a knowledge gap by providing guidance on the development and optimization of two mobile health interventions for oral health promotion and behavior change using MOST. And we have had the privilege of having Merna with us since February, doing a little stint here with Cadio. And so Merna, thank you for being with us and presenting today.
Thank you so much, Kate, for the introduction. The past 4 months training at Cadio have been very fruitful. So thank you so much, Linda and Kate, for the wonderful time. I would also like to thank my academic advisors for their continuous support and help with the project. I believe they're with us here today. And of course, a huge part of this project was a teamwork, and it happened because of the help of my colleagues in the department. So thanks for them too. You can find more details about our study in our published study protocol and trials, and hopefully all the preparation phase work we will be discussing today will also be available soon. Please feel free to stop me anytime if you have any questions, and I'm looking forward to the discussion afterwards. So a brief impetus for our study. Early childhood caries is one of the most prevalent chronic diseases affecting children worldwide. And of course, we know that regular toothbrushing with fluoridated toothpaste is a highly effective home care measure to prevent early childhood caries. And since that the American Academy of Pediatric Dentistry recommends parental supervision of children's toothbrushing during the preschool years, this renders dental health education of caregivers as one of the best approaches to control the disease. So multiple interventions have been developed targeting parents of preschool children, but the problem with those interventions is that they usually consist of multiple intervention components, and they're usually evaluated as a single package in an RCT. So we don't really know which of those components work, which don't, and which work particularly well together. And also, unfortunately, sufficient descriptions of how the interventions were developed, delivered, and evaluated are lacking, with only a few of those studies are being underpinned by a theoretical framework. So our goals for the study is to increase parental supervised toothbrushing and toothpaste use. And our outcome measure is the decrease in the plaque accumulation on the children's teeth. Using the multi-phase optimization strategy framework, we designed a 2 to the 3 factorial trial with 3 intervention components. And I will be talking about how we develop the components later. And this means we have 8 experimental conditions. Each of those intervention components have 2 levels. Either they're set to no, the intervention is not delivered, or yes, the intervention is delivered. Our eligibility criteria is mothers of children between 2 and who have children between 2 and less than 5 years of age, who have children who have dental plaque index scores of more than or equal to with visible plaque accumulation on their teeth. The mother has to be literate and owns a mobile phone with WhatsApp application or where WhatsApp Messenger can be installed. And the mother is excluded if she has a child with a definitely negative behavior, if the child is physically disabled or medically compromised, or if he needs any emergency dental treatment. Our conceptual framework was based on the theory of planned behavior, which posits that intentions are the best precursors for behavior, and that they're affected by the attitude of an individual, his subjective norms, and his perceived behavioral control. And so we started developing 3 intervention components, each of those intervention components targeting one of the constructs of the theory of planned behavior, in addition to a constant component that will be delivered to all mothers, regardless of the experimental condition they are randomized to, in an aim to change a mother's intention to brush her child's teeth. And hopefully this will bring about the altered behavior in the increase in the frequency of toothbrushing and use of toothpaste. And as I was saying before, our expected outcome measure is the decrease in the plaque index score. So our 3 intervention components being tested are the motivational interviewing sessions, oral health promotion messages, and storytelling videos. And I would like to talk about how did we develop the interventions. So for the oral health promotion messages, we developed 24 oral health promotion messages. They were developed in very simple language for all mothers to be able to understand them, mothers of different backgrounds and socioeconomic levels. And they were developed according to variations in 3 things: the content in which they were delivered, the norms, and the sentiment. So it's either the message was talking about the content, about how it has an impact of oral health on the child's self-confidence, the facial aesthetics, speech, or the cost of treating oral diseases, and then the norms in which they were framed accordingly, whether they were targeting the family, friends, or the community in general, and then whether the message had a positive sentiment showing the benefits of good oral health or negative sentiment warning against the outcomes of poor oral health. So this is an example of an oral health promotion message with a positive sentiment showing the impact of facial aesthetics due to good oral health and how this will be perceived by friends. Brushing your child's teeth twice a day with a toothbrush and toothpaste will help make his smile more beautiful in front of his friends. Moving on to the storytelling videos. So we developed 14 scripts according to a model of storytelling known as the and, but therefore model of storytelling. And the 14 scripts started narrating the experience of mothers of children who experienced early childhood caries. So for example, one of the scripts below, plaque causes early childhood caries and the child suffers, but brushing can prevent tooth decay. And therefore it's important for mothers to brush their children's teeth twice daily. After we developed the scripts, those scripts were used to develop videos by applying the success criteria. So success is a marketing communication strategy that posits that for an idea to be sticky and successful and induce behavioral change, it should be characterized by being very simple, has unexpected information, concrete, credible, includes an emotional aspect, and in the form of story. And we started applying each of this criteria to our videos. For example, for credibility, we had dentists in their dental attire talking about how to prevent early childhood caries within a concrete narrative. And then any information that was in the video was based on scientific evidence and in the form of a story. We then, from those 14 scripts, we were able to produce 24 short videos, each 1 to 2 minutes, and with about 2 of those videos showing the story of each of the scripts. In addition, we developed another introductory video to introduce the series of storytelling videos to the audience. And then we uploaded the videos online on a YouTube channel. So in addition to the oral health promotion messages and storytelling videos, we also have a constant component that mothers are going to receive, and it will emphasize the importance of primary teeth, the correct feeding habits, the recommended sugar intake, and the age-appropriate oral hygiene practices. So as a summary, we have 3 intervention components and a constant component that targets the core knowledge of mothers. The constant component will be delivered once at baseline in the form of pamphlets in the clinic during the enrollment at baseline. The motivational interviewing will be delivered once at baseline and then followed by 3 phone calls for a period of 6 months. And then the oral health promotion messages and storytelling videos will be mHealth electronic messages delivered via WhatsApp Messenger. Their frequency of delivery was determined during our feasibility pilot study. So we conducted a feasibility pilot study to be able to assess the acceptability and feasibility of our intervention components and to determine the preferred frequency and timing of receiving the interventions, and also to set our optimization objective. So the feasibility pilot study, each mother, so at first we did not power the pilot study, and we didn't have any hypothesis testing. We just wanted to assess the acceptability and feasibility. So we recruited mothers until information saturation occurred, and we had a total of 16 mothers enrolled in our pilot study. So each mother randomly received 2 of our oral health promotion messages and storytelling videos, and a 15-minute of the motivational interviewing session. The mother then participated in an audio recorded 40 minutes long semi-structured interview where we started asking the mother 6 open-ended questions to assess her acceptability for the intervention components based on the framework of acceptability. So we asked the mother's question about the perceived effectiveness of the intervention, the effective attitude, the perceived burden for her to be able to participate, if there is any ethicality concerns, and opportunity costs. And in addition for that, for triangulation, mothers also responded to a paper-based questionnaire assessing their perceived and experienced acceptability towards the intervention components. And also within the questionnaire, we also asked about the preferred frequency for the mother to receive the intervention, the preferred timing of receiving the intervention, and the maximum amount of time they were willing to spend receiving the interventions. So we identified 2 main themes from our qualitative study, and they were related to how mothers perceive the intervention components. So mothers felt like they had very positive perception of the components. They were very satisfied with them, and they explained that the interventions motivated them to brush their children's teeth, that they acted as reminders and reminded them when they forgot, even if they knew the information. Also, mothers felt like the more the intervention components explain the harmful effects of caries on their child, how it would affect his performance at school, how it would affect his facial aesthetics, it had a greater impact on the mother, and she wanted to go brush her child's teeth immediately. And then the storytelling effects of videos, mothers explained that it was very relatable, real, and that they've seen or heard about someone, or they've experienced the story themselves with their children before. And then there were a theme related to the advantage of electronic interventions, and that mothers hold their phones all day. It's very easy. There is no cost associated with receiving the interventions. And then the second theme was related to time and commuting as problems with the intervention components, and those were related more to the motivational interviewing, because mothers felt they're not willing to spend more than 30 minutes receiving even a phone call, like a follow-up phone call, just talking about, they'd have, especially mothers who were working. In addition, 80% of the mothers preferred receiving the messages and the videos once per week, after 8 p.m. to 2 a.m. because they felt that was the only time they have that's free after their child's sleep, and that 60% indicated they could allocate a maximum of 15 to 30 minutes to receiving the interventions. Accordingly, we've set our optimization objective, and we identified that the time a mother is willing to spend receiving the intervention is the most important factor. So putting implementation in mind, the intervention was designed to be offered as part of a preventive package for mothers of young children in the Mother and Child Health Centers in the Ministry of Health and Population in Egypt. So usually the dentist that are employed in those facilities are paid constant salaries that are neither linked to the number of patients they manage or the type of service they provide. So the critical factor here is the uptake of the intervention components on the mother's willingness to engage with the components. So time was considered to be the most important factor for this engagement. And thus our optimization objective is the lowest plaque index score obtainable without exceeding 30 minutes of a mother's time receiving the intervention. Which means that after our trial, any intervention that took more than 30 minutes to be delivered will be excluded. So just a checkpoint, I've talked about our trial design, the conceptual framework, and how we developed our intervention components. I'll briefly touch upon how we calculated our sample size, how randomization will go, and some talk about calculations of the main effects and interactions and our decision-making process. So our sample, the study is powered to detect a moderate effect size of 0.06. Our study power is 80% with an alpha error of 5%. And accordingly, we had a total sample size of 126. We rounded that to 160 to correspond to 20 mothers in each of the 8 experimental conditions. And then randomization. I've added here just a hypothetical, just random numbers about, so to be able to explain more about the randomization process, we will be using a restricted type of randomization with a permuted blocks of 16. In the literature, it is said that it's usually preferable to have a permuted blocks which are equal to the experimental condition or a multiple of that experimental condition. So based on previous studies that had 2 to the 3 factorial trials, we decided to go with a permuted block of size 16. So when a participant is enrolled, the mother will be randomized to the condition listed in the permuted block until we've finished the permuted block, and then we will move on to the next permuted block as follows. Which means that in each experimental condition, 20 mothers will be randomized to each of those experimental conditions. So for example, for the motivational interviewing, a total of 80 mothers will not be receiving the interventions, and a total of 80 mothers will be receiving the motivational intervention. Moving on to the main effects and interactions. So if you want to calculate the main effect of motivational interviewing, the motivational interviewing main effect will be calculated by subtracting the mean responses from conditions 1 to 4 from the mean responses of in conditions 5 to 8. And the same follows for the oral health promotion messages and storytelling videos. For example, the main effect of oral health promotion messages will be calculated as the mean difference of experimental conditions 1, 2, 5, 6 from 3, 4, 7, and 8. Then if we want to calculate a two-way interaction involving the components motivational interviewing and oral health promotion messages, we'll have to first calculate the effect of the motivational interviewing when oral health promotion messages are set to yes, and those are experimental conditions 7 and 8. And then we will calculate the effect of motivational interviewing when oral health promotion messages are set to no, and those are experimental conditions 5 and 6. And then there will be a two-way interaction if there's a difference between those two, between the effects of MI when oral health promotion messages is set to yes, and the effect of motivational interviewing when oral health promotion messages are set to no. Finally, I'll talk a little bit about the decision-making process. So based on our protocol paper, we will be using the component screening approach. So if a component has a main effect with at least a moderate effect size, we will choose the yes level for the inclusion for its inclusion in the intervention. And if the component does not achieve a moderate effect size or has an effect in the wrong direction, such as, for example, increasing the plaque index, the no level will be selected for this component. So this allows us to include only the effective components and eliminate the components which have no use. And then accordingly, an initially selected component may be deselected if it interacts with another component which undermines its effect. And we could then choose a component not initially selected if it interacts with another component to enhance its effect. And the combination of those components will fit within the constraint of the optimization objective will be selected for inclusion in our optimized intervention package. By this, I finished my presentation and I'm looking forward to the discussion.
Wonderful. Thank you, Merna. We will certainly open it up for conversation, questions, discussion, and to get us rolling, you can feel free to put a comment in the chat, and I can moderate that, or you can unmute yourself and ask Merna directly. Wonderful. Linda, would you like to? Wait, you're muted.
Yeah, this is, of course, really interesting. And I just wanted to ask you, can you talk a little more about what your next steps would be? So let's say you conducted the optimization trial, and let's say only one of the components ends up being successful. Would you go ahead with an intervention then? Would you want to conduct a follow-on optimization trial with some new components? So can you talk through maybe 10 years of research in this area?
So I love the idea of the continuous optimization of the interventions. So I believe if only one of the interventions work, then it's always good to go back to the preparation and see what we could change and how we can change it to make the intervention more optimized before we could actually move to the evaluation phase where we would evaluate our components as a package in an RCT. So, yeah.
But how many components would you feel like would have to be successful in your mind for this to be worth going ahead to implement the intervention? Do you have any preconceived ideas about that, or are you just going to kind of wait and see what the effect sizes are?
I think at least two of the intervention components might allow us to move forward. And it also depends on the effect size and what we will see from our factorial optimization trial. Yeah.
And then who would you expect would be delivering the intervention if it, let's say best case scenario, 2 or 3 components work, and you're able to put together an intervention that you feel good about. What would your immediate next step be? Would you seek funding to do an RCT? Would you want to go ahead, an evaluation RCT? Would you want to go ahead to implement the intervention? What would your next steps be?
For the next steps, I believe I would want to evaluate the intervention as a package in an RCT, and then hopefully we would be able to take this package to the Ministry of Health and Population to be implemented within the mother and children health centers. So those would be our future plans.
And one more just question or comment I had. I think a lot of people who are familiar with MOST know about it more from a behavioral perspective, but you have a biological outcome. Could you just talk about that for a moment, because it's unusual to have such a clear outcome as you have that can be used to evaluate the components?
Yeah. So we could definitely assess the change in a mother's behavior by seeing the increase in the frequency of toothbrushing. But what's good about the assessing the plaque index score is that it's very objective. So when a child comes to the clinic, and he has a very high plaque accumulation level, it would be very nice to see how that would change over a course of 3 months or 6-month period. And then based on the score, we'd have a total score of how the child's plaque accumulation level was at the baseline and after 3 months. So that's what we're planning to do. Yeah.
And how is that measured exactly?
So we usually, the plaque index score has scores are given from 0 to 3, 0 being no plaque accumulation on the child's teeth, and then up till 3 where there's visible plaque accumulation covering more than 2/3 of the surface of the tooth. Mm-hmm. And we measure that by having 6 index teeth. We measure or see the 6 index teeth and then give a total score for the 6 teeth.
Mm-hmm.
When Merna presented to my class earlier this semester, we really dug in on how you measure this plaque. So, because it is really different, Merna, and I think Linda makes a nice point that for those of us who think about most often, it's with a behavioral kind of outcome. So it's interesting to hear you talk. John Ziak, you have been wanting to ask a question.
I was just wondering, supposing you got an effect size estimate that was like 0.45, I think technically, according to what you wrote, you would have to say that was inactive. But if you think about it, if the true effect size is 0.51, say, you still have an almost 50% chance by the sampling distribution of getting it less than 0.5. So your power to detect, like, it seems like you're hurting your power a lot by saying not only does it have to be significant, but it has to be 0.5 or standard deviations or greater.
I think my academic supervisor, Dr. Maha, might be able to help with that too.
Well, we could talk about it afterwards if you like.
Yeah.
All right. Well, it's good. You always can count on Dr. Ziak to bring you the question about sample size and power.
Well, I just don't want you to throw away anything good. And this isn't. I don't think you're promised to anything because this is. If you were reporting confirmatory results, you'd have to follow your protocol exactly. But for whatever you're going to recommend for your RCT, it seems to me you still have some room for your personal judgment, in my opinion.
Yeah, I think that's a very good point to consider. True, yeah. And I would like to have a discussion with my advisor about that more, and how the decision-making process would go further.
Yeah, and the way you describe the decision-making process, it's based more on what I wrote in my book. Yeah. But as we all know, there's some new research on this topic, and you'll be able to use some new and I think probably better approaches when the time actually comes for you to be making those decisions.
So yeah, I based I based the decision-making process on what we wrote in our protocol paper, but with Jillian's work, Jillian Strayhorn, it would be very nice to actually apply a more posterior expected value approach, rather than a component screening approach. And I think that's going to change a lot about our decision-making process.
I'm noticing that Maha, your hand is raised. Would you like to jump in?
Yes, thanks for the great work that you're doing, and thanks for Zara. I know she must have enjoyed her stay a lot. we look forward to all the knowledge transfer that we'll be able to get. And back to Dr. Ziak's question about the sample size estimation and the effect size. Well, I think you're better suited to know that this is like almost groundbreaking work in the field of dentistry. And you might imagine how, I don't know how to phrase it, how stressed, worried we were when we were proposing this kind of study. Yes, well, to the community of dental public health people in Egypt and actually everywhere. So we needed to follow the sort of like the conventions, and I don't think anybody in the field of dental public health would accept something less rigorous than a very set effect size that is spelled out and with the lengthy power statement that you might see in the protocol paper, Merna's protocol paper. That said, I think when we go to the factorial study, and with the knowledge that I know Merna is going to get from the period that she'll be spending with you people, we may need to have some a further look, I would say, for what we have been proposing, and try to come up with the most reasonable path to follow, so that we do not end up, like Dr. Ziak said, throwing up useful material. So I think we'll be learning our way through this, and we hope to see it come up nicely settled on the other side. So thank you. Thank you for the question. Thank you for the observation. Thanks.
I think that that's a wonderful point to maybe lead to, Merna Maha, can you share your thoughts about why most and why that was the approach to adopt? And really, you are the trailblazers in bringing this into oral health. So I'd love, if you don't mind, just to take a second to hear your thoughts about why most is the right answer for you.
Like I was talking about our impetus for the study, there are multiple intervention components, but multiple interventions targeting parental supervised toothbrushing. But the problem is that most of the interventions are delivered as packages in an RCT. There hasn't been any study or in dentistry that is assessing which of those intervention components work, which do not work, which work well together. So I believe this is very important, not to spend a lot of time and resources and energy on intervention components that do not work. And that's why most.
Well, yeah. Great answer. We agree.
Yes, I'd like to add a bit to this. Well, we have this landmark paper in the field of we call it dental health education. I think it was in the late 90s and stuff like this. What it basically says is that if you're going to present people with health education, which is what you try to do when you are trying to change their behavior without providing anything else, like a fluoride application, like sealant. These are the preventive agents that we use in dentistry. You'll end up mostly with no effect. So this is the perspective. Because of this, what people usually do is that they throw in everything that they can basically think of, anything that they can have access to. And then we fast forward to 2020 in the summit of the BHE-SAR group, when I don't know how it went, whether people invited Kate to talk or she knew someone, whatever happened, it was like, I attended this virtual summit, it was during COVID, and this talk about this technique, which had the nice complexity of being sort of like aligned with engineering stuff, which is very dear to the way we'd like to have things. It has this kind of precision which would give to the people in the dental public health community the idea that health education is just not like about getting to lecture audience about brushing and flossing and not eating sweets and stuff like this. So the technique was very appealing. And well, while we were at it, I would say that Merna actually quite jumped into it. It was scary at the time. We had virtually nothing except what the two books that Kate shared, Linda's books in the summit, and we tried to find our way through this, and I hope it works eventually.
And I didn't mean to leave that question for you to talk about me, but I'm so thrilled that
No, what it is actually about knowledge transfer, and this is very important because people in one discipline rarely have another look about what other people are doing. And I think the field of behavioral sciences in dentistry is sort of like ready to make the next move. Many people are interested in things, and COVID has shown that we need to be doing something about this. In Egypt, we have a huge problem of oral hygiene. Egypt has the second lowest prevalence of toothbrushing among all countries. And this is for 12-year-old children who are most likely to be supervised, to have supervised toothbrushing in schools. So you can imagine how worse the problem would be in other age groups. So we do need an intervention. The dental community needs more robust behavior change approaches. So I think MOST is very well suited to help us along this way. Yes.
that's wonderful. And what a nice little snippet testimonial. Well, awesome. So maybe I can ask one more question, Merna, and others if you have other questions that pop up. But Merna, you just completed our training on intervention optimization. And one of the things that we talk about in that is picking the effect size to use for your sample size calculation. And I'm wondering if you could speak a little bit about how you identified that effect size in this situation, given that your field hasn't looked at different components of an intervention. So how did you settle where you settled?
We chose a moderate effect size to detect we chose it based on what's known in the literature about how to moderate effect sizes using factorial ANOVAs. And that's how we based our decision.
Would you do anything different?
Anything different? Can you clarify more about that?
Well, I mean, so we talk in the training a little bit about different ways that we can think about how to estimate the effect size of a component, because oftentimes we don't know. And so things we talk about include, going to the literature, seeing what we have for different components, or picking one that you feel is the smallest that you would be willing to include. So I'm just curious, would you do anything different?
Now, if I'm choosing like my effect size, no, I think I would go with the same approach, because as Dr. Mahad touched upon, the approach is very new. The dental community won't be accepting anything below a certain effect size. So I would go with the same effect size.
Totally fair. Just thought I would use that to hear what you had to say. Okay.
Well, this is so interesting. Can I just say, Merna and Dr. Maha and your other collaborators, you'll always have us. If we can be helpful to you as you move forward in this, please call on Cadio. We would be, very happy to comment on what you're doing and offer advice. We can, arrange a Zoom get together sometime if you just want to talk about what you're doing. So it's been really, really great having Merna visit, but we're also really excited about the transfer of knowledge that you talked about. We feel like that's why we're here. And so we would really love to be able to facilitate that going forward.
Yeah. That would be amazing. And that's the plan.
That is the plan.
Good. my experience so far has been that there is a lot of resistance to these ideas in places where the classical treatment package approach is deeply entrenched, but in other areas where behavioral interventions are just kind of starting to get traction, there's more openness because there's not an industry built around the classical treatment package approach. So I have a feeling that you'll find that there will be openness to these ideas for many of the reasons that Dr. Maha said. I think taking a more engineering type approach will probably appeal to people in dentistry. It seems to me.
Yeah, definitely. Yeah.
Well, I want to say thank you again, Merna, for spending 4 months with us and for sharing a lot of knowledge with us as well. And we are excited to see what you do next. And to the broader attendees, I want to say thank you for joining us. This is the end of our 2023 spring webinar series, but stay tuned for our fall lineup shortly. And if you missed any of our prior webinars, they are on our website. So we invite you to look at those. And with that, have a wonderful day. Thank you.